and very warm welcome from on behalf of Team Bayer Oncology. So we are going to start our session, sir, and very warm welcome from Team Bayer Oncology in the new week of clinical conversation. The first topic with reaching new heights in the MHSPC care. So wish you all the best, sir. I'm going to invite Dr. Parat, sir, for his session. Welcome, sir.
Thank you. Thank you for this nice introduction, and thank you, Bear, for this opportunity to introduce this new molecule what we are practicing in our day-to-day life. So I am sharing my slide.
Here.
The topic of metastatic hormone-sensitive prostate cancer. We all know that prostate cancer is a disease of elderly. So before introducing the hormonal therapy, we were treating only with the ADT, that is like leuprolide, or maybe bicalutamide, like that. And that time the prognosis was not very much good, and it very quickly converted to the CRPC part, that is castration resistant part, and that at that time the overall survival was not very much good. But with the introduction of many hormonal therapy and the new novel hormonal therapy, what we can achieve in our day-to-day practice, that um, this disease is much more controlled, and the patient having a longer life with a very good quality of life. So first, this slide, what we are seeing, that uh, the prostate cancer landscape, that this disease starts with presents with patients of elderly age, and at the time of presentation, most of them are localized, and some of them are also locally advanced or in metastatic cancer. Then we treat them. Then after certain period of time, there will be biochemical relapse or recurrence, that very much coincide with the increase of PSA, and that can be converted to either non-metastatic CRPC, or maybe metastatic portion, or sometimes patients diagnosed as a metastatic hormone sensitive uh, prostate cancer, or maybe progressed from the before diagnosed cancer. And then we are continuing the ADT, that is the main treatment part. We suppress the testosterone by giving leuprolide kind of drug, or maybe by surgical castration by orchidectomy. And after certain time period, there will be say metastatic CRPC, the castration resistant part. In that, the testosterone will be below normal and suppressed, but there will be change of biology of the prostate cancer, and this is very much aggressive type of disease. And patient, almost all this goes through this kind of landscape, and this metastatic CRPC is very much lethal, and only gives an OS improvement of maybe 2 to 4 to 5 months only. So the main topic of our discussion is the opportunity to delay uh, metastatic CRPC, and further improvement of the outcome. So this image, what we are trying to get, that this is a stampede trial which was conducted almost 10 years back, presented in the urology journal, and which showed compared almost multiple arm, like 7 to 8 arms, and took almost 1,000 of patient. And here this finds the role of ADT, and from this trial, what we can say that these patients have a failure-free survival of median failure-free survival of 11 months and overall survival of 42 months with the giving of ADT, and which we can say that there will be delayed progression to CRPC. That is the main bad thing, and with the help of CRPC, there is delay of almost 30 months of delay in death, and but eventually the patient die of the disease with a median survival of maybe 3.5 years only. So what we can do offer that, and also the Stampede trial, which showed the role of radiotherapy in the prostate in metastatic hormone sensitive cancer, and in failure free survival. And if we see the bony high burden disease or low burden disease, which we can say that in bony metastasis less than 4 metastasis, there will be the definitive role of prostate radiation therapy, which um, replicates to improvement of failure free survival, and also the overall survival with addition of radiation therapy to the local prostate in low volume disease, that is less than 4 bony metastasis is there. But the role of radiation therapy is not very much shown in the high volume disease, that is if the bony metastasis is more than 4 bony metastasis. And this the basis of this trial was from the UKPR3 trial, which continued the ADT for the lifelong. And the benefit of radiation therapy not only confined to the event free survival or the OS benefit. There will be much more benefit like metastasis free survival, like improved castration resistance free survival, decrease PSA relapse, like that. Uh, this is the landscape of how the addition of therapy, multiple addition of therapy comes with development. And if we see that in uh, 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 from the very beginning, the docetaxel was the uh, drug of choice, or it is the standard of care, which was proven from the chartered or Stampede trial, then also Stampede trial, which approved the role of abiraterone. Also abiraterone was proved in latitude trial. And then came the role of enzalutamide, which has some other benefit like avoidance of steroid in abiraterone. Then Titan showed the benefit of apalutamide. And lastly, the addition of chemotherapy benefits the patients, uh, which was shown in the Peace 1 or Arasens trial. So we'll be discussing later regarding the Erasmus trial, which is our main topic of discussion. And
Sir, should
we
I share, sir? Sir, from my end, should I share the slide? If
slide is not moving, right?
no, no, not moving, sir, actually. So
Okay, okay.
if sir, it is any
Let me
issue, sir,
reshare.
then I can share, sir, if any issue. Now, okay, sir. Now, okay. Now, okay.
No, let me reshare.
If there is any issue, sir, I can share from my end also, if you feel comfortable, sir.
No, not an issue. Let me try once. Then
No, sir,
it
no
is
issue. It's
moving
okay.
right now.
Yeah. Right now, it's okay. Absolutely okay, sir.
It's okay.
Okay, sir. It's moving. Right now, it's moving.
Okay, okay. So
Yeah.
sorry for the
No
inconvenience.
issue. No.
Um, regarding the charter trial, which showed the role of docetaxel in metastatic hormone sensitive prostate cancer, even the role of docetaxel is very much pronounced in both in high volume disease and also the low volume disease. Though the in low volume disease, it is not very much p volume is not supporting for the low volume disease, but in high volume disease there is median overall survival of 51 month versus 34-month with the addition of docetaxel. So in latitude trial, what they have shown that the role of abiraterone, it was the first trial when the hormone based the novel hormone based therapy was actually shown some benefit in different type of patients. And the problem is that the difference, they were comparing the role of abiraterone with the placebo arm. So what we can say that the comparator arm did not get any much of treatment, nothing else, only they were receiving the leuprolide kind of thing. So, and the if we see that the time of castration status was 7.4 month, and the progression was only 33 months. And with the addition of abiraterone in the high risk of metastatic hormone sensitive prostate cancer, the overall survival was 51.8 month in the abiraterone arm, and only in the ADT arm was 36 months. We all know that abiraterone inhibits the enzyme which is responsible for the conversion of testosterone. With the addition of there was suppression of cortisol also. This enzyme also responsible for that. For this reason we add prednisolone in that, and prednisolone itself has multiple side effects. Even only very lower doses of prednisolone or prednisone like 5 mg, it has multiple side effects with the addition of abiraterone. And this prednisone helps in the suppression of the mineralocorticoid activity, and also, and there will be a hypertension of almost 23%, like in grade 3 or grade 4, and there will be a hypokalemia of approximately 12%. This number is not very much less, and we also this number varies very differently in our day-to-day practice also. In Titan study, the novel therapy apatolamide, they compared the apatolamide plus ADT versus the ADT portion almost to more than 1,000 of patient, and there is significant improvement in the progression-free survival and also the overall survival. In subgroup analysis, the hazard ratio is very much impressive, both in the low subgroup and also in the low volume disease and also the high volume disease. In They have used the definition of high volume or low volume like what you used in chartered as used in Titan study also. In Injamin trial, they evaluated the role of enzalutamide uh, mm, in metastatic hormone sensitive prostate cancer. But in comparison to the other study, they have compared enzalutamide plus ATT versus the non-steroid anti-androgen like the previous generation, like bicalutamide, flutamide of kind of thing, and which showed that mm, uh, overall survival is overall survival and uh, progression-free survival is very much good, and both were uh, mm, uh, had a good uh, hazard ratio. And this subgroup analysis, what they have showed that the significant p value was supported for low volume and high volume disease. So what all these trial, what they have showed that the role of only anti-androgen like of the therapy, but yet not they have not added the anti-androgen with chemo part with hormonal suppression. And for this reason, here comes the uh, peace one trial. This is a 4-arm study, and when the study was conducted almost 10 years back, recruitment started. They included the metastatic, de novo metastatic uh, uh, hormone sensitive prostate cancer, uh, uh, divided the disease as per high volume or low volume disease, and other inclusion criteria like no prior cytotoxic therapy, less than 3 months of ADT, and other stratification factor like ECOG score, ECOG performance status, metastatic site, metastatic site like lymph node, bone, or visceral metastasis is there or not, or docetaxel was given or not. From the recruitment process, docetaxel was option like as per physicians like docetaxel can be given, docetaxel may not be given, but uh, after the latitude result came, then they were trying to include more docetaxel in patients, and as docetaxel was the standard of care at that time. The arm was divided with the standard of care, and the standard of care was ATT plus minus docetaxel. Docetaxel was an optional from the starting of the trial, but later they included. And with radiation and with or without abiraterone, and with or without radiation. So the fourth arm, but the trial did not intend to conduct the role of triple therapy like docetaxel role. Their primary endpoint was not to evaluate the role of docetaxel in this trial. The primary endpoint was to evaluate the role of abiraterone with the role of abiraterone if they are added with the standard of care. And the primary endpoint was radiological PFS and OS, and there were multiple secondary endpoints like five or six. Um, if we see the mm, graph curve in peace one trial, in the high volume disease, that standard of care plus abiraterone had significantly better in mm, this high volume disease, but it is not very much significantly shown better result in the low volume disease. And lastly, the uh, darolutamide, which was conducted in RSN's trial. It is a phase 3 global randomized trial, double-blinded, placebo-controlled study. Almost 1,300 patients were taken. All patients were metastatic hormone-sensitive patient, and the almost or 90% of the patient received docetaxel, and the stratification done was extension of disease with the metastatic burden like metastatic M1A versus B, and other stratification factor was alkaline phosphatase. There was two arm darolutamide plus docetaxel. 6 cycle of docetaxel was received. All patients received ADT as the primary treatment, and the other arm was placebo plus docetaxel. The data collection started from November 2016, and cutoff was in 2021. This RSN study was specifically answered the question that we have a better solution in the Peace one trial, that in subset analysis the role of triplet therapy was established. But in Peace one trial, the main intention was not to uh, see the role of chemotherapy, but it was proven the role of chemotherapy in a subset analysis. So, and this study was designed before the results of latitude trial. So, for this trial, this is very much important. The role of addition of yeah, docetaxel plus hormonal therapy, and they showed some additional uh, result and in subset analysis also. And if we see that patient receives in receiving the docetaxel uh, as a part of treatment plan in RSN study, almost 90% received docetaxel. But in Peace one trial, almost 70% patient received docetaxel. The primary endpoint in this trial was overall survival, and the secondary endpoint was time to castration-resistant prostate cancer, time to pain control, symptomatic skeletal event-free survival, time to first symptomatic skeletal event, time to initiation of subsequent antineoplastic therapy, time to worsening physical symptoms, and safety, and time to initiation of opioid for use for more than 7 consecutive days. So, if we see the trial, the overall population was there. In overall population, there was clear improvement in the overall population in darolutamide triplet therapy, and there is this benefit was seen in both high risk and low risk patients. With a in high risk patient, there was almost 29% uh, improved in survival, and in low risk patient there is almost 38% improved survival. Even the other secondary endpoint like uh, time to CRPC was very much significantly improved here, and also there is almost 64% risk of reduction to progress to castration resistant part patient receiving the triplet therapy. Also the 61% reduction uh, to the time to first subsequent antineoplastic therapy, and uh, the 21% reduction in time to pain progression, and 29% reduction in in the skeletal event. Uh, so this is the subgroup analysis uh, in which was presented in the ISMO also, and also in the European Journal in 2024. With comparison of PSA response, and the what they have found that if the PSA is undetectable, does it correlate with the other survival part? What they have seen that this PSA response, that is undetectable PSA, like below point 0.2, is very much higher if we treating the patients with this novel darolutamide plus docetaxel arm. And at any time there is almost 67% patient achieving the undetectable PSA, and almost 28% if patient is not receiving darolutamide. And this is also reflected that undetectable PSA, there will be improved event-free survival, and also reflected with long-term overall survival if their patients having undetectable PSA. And more than two-third of the patient reach the uh, below level of undetectable PSA. Even in the high volume disease, they have shown that this undetectable PSA was very much pronounced with the darolutamide arm. That is, at any time, 62% patient had undetectable PSA, and only 25% patient had undetectable PSA if they are receiving only the placebo. And also this relates with the PSA progression that is converted to CRPC in undetectable PSA. There is high even pre-survival probability and overall survival also. The overall survival and PSA progression is very much less, and overall survival is high if there is undetectable PSA. So what we can say that this darolutamide triplet achieved long periods of no disease progression and also improves the overall survival. Even in low volume disease, this also replicate like from the high volume disease. And even in ASCO news, what they have uh, uh, in a subset analysis, what they have said that irrespective of the volume, like low volume disease, high volume disease, or they even this subset analysis they have done even in high risk disease or low risk disease also, all with this PSA detection. And what they have found that if patient achieving undetectable uh, PSA, then this darolutamide have helping the patient to uh, increase the time to PSA progression, like converted to CFPC is in a long duration and having an overall survival benefit. So what we can say with this RSN study that this patient, if able to tolerate, then even irrespective of the lower or higher risk or volume of the disease, we can add docetaxel and also the darolutamide. And this high volume or low volume disease helps us to get an estimate of how this triplet therapy will respond, or and this life expectancy, all this depends upon the how we are going to treat. And patient needs to be discussed about this new uh, uh, vision, like that PSA decrease is also a part of our uh, practice change, what we can do in our day-to-day life. So thank you for your patient hearing. Here
Thank you,
I
sir. Thank you. Thank you, Parag sir, for your very nice and deliberate presentation on this topic on reaching in the new heights in image-specific care. So really, it's your presentation is a new era in adding a new feather also in the new Veka part as a new era. So before we are going to start for the next session, which is on with Dr. Satish sir, I just sorry to inform that just few minutes back, Satish sir informed that during some in this family some medical emergency, someone is admitted, so he could not be able to join. So very much sorry for the inconvenience. So and from part of the organizer, it's sorry for the inconvenience of on behalf of Satish sir. But wanted to thanks Dr. Parag sir for his nice presentation, and for in future we are going for the same meeting further also. Thank you, sir. Thank you very much.
okay, thank you very much, thank you Pat, for this opportunity. And thank you
Thank you,
for
sir. Thank you, sir. Thank you. So I think there is no such question. So is there technical team is with me?
Yes, sir.
Yeah, yeah. So there is some medical emergencies on behalf, as I announced on behalf of Dr. Satish, sir. So I think we can conclude the session.
Okay, sir. No worries.
Yeah, yeah, sure. And thanks to technical support team and all other